What is systemic lupus erythematosus? Or I would also like to refer this as SLE. This is a multi-system autoimmune disease that can affect actually any organ of the body. So there is a multi-organ system involvement, and this is characterized by presence of multiple autoantibodies. We all have a immune system which is like the army of our body, which protects us from attackers that come from outside. For example, the bacteria, the virus, etc. But this immune system is wonderful. It does differentiate what is foreign and what is our own. That means it does not attack our own tissues. But then, in some people, the immune system, for reasons that are not very clear, starts attacking our own tissues, our own organs. And this is what we call an autoimmune disease. Say, I would say there are no large studies that have been done. As per one quote, it was like 2.5 per 1 lakh children. And this would be 5 times more common in adults. If you take it as to be 10 to 20 per 1 lakh, that is the kind of stats that we are looking at. Yeah. The common age at presentation when a patient of SLE comes to a physician is 20 to 30 years of age. That means it is young adult females that often have these issues. However, I am a pediatric rheumatologist and I often see children with SLE. And in children, majority of them come around the age of 12 to 16. Now you can understand these are adolescents who are having these issues. Somehow, this disease predominantly affects females, and there is a reason behind this. Hormones are said to be one of the important factors that can contribute to disease, and that is why females are more likely to be affected than males. Now, if you ask me how common is it in females compared to males, typically in adults, that is beyond the age of 18, you can see the ratio is as skewed as 9 is to 1. That means 9 females to 1 male. However, that is not true in children. In children, the ratio is 5 girls to 1 boy. Very rarely, I would say very rarely, SLE can affect children below the age of 5. That means young children below the age of 5. And often, this group of SLE is very different from other forms of SLE. These are the genetic forms of SLE. And in this particular subgroup, males and females can be equally affected. Now, generally, if you ask me, how common is this disease when you compare it with adults? So, we like to say that 20% of SLE typically starts in childhood. That means if you have 5 patients with SLE, one would have started at a young age before the age of 16. And typically, statistics say that this disease, especially in children, can be seen somewhere between zero point 0.3 to 2.5 per 1 lakh individuals. This is statistics for pediatric lupus or childhood lupus. A very classical symptom that patients with SLE come to us is the malar rash, the rash over the face, what we call the butterfly rash. In fact, it is this butterfly rash that is so classical that if you look at this rash, one can easily diagnose SLE. However, these patients can have several other problems: significant hair fall, repeated ulcers in the mouth, vague aches and pains. Sometimes their joints are swollen, what we call arthritis. As I mentioned before, this disease can affect any organ of the body, and kidneys are a common target. I would say almost 30 to 50% of patients may end up getting a kidney problem where the kidneys are being attacked by the autoimmune disease. And we call it the lupus nephritis. And other organs that can be affected, especially bloodlines, can be affected. And when blood cells are affected, we see these patients having very low hemoglobin, sometimes very low platelet counts and white cell counts. And occasionally, the brain can be affected, and even intestines can be affected. A subgroup of these patients have increased risk of blood clotting. And if they have a clot in the blood, they can develop something like stroke in the brain. And these patients with SLE who have increased risk of clotting, we always look at a at a group of antibodies which are called the anti-phospholipid antibodies. So any patient with SLE, we routinely test them for this risk of clotting. No two patients of SLE look alike. There may be a patient who just comes with a malar rash and does not have kidney involvement, and there could be a second patient who just comes with severe kidney involvement, severe kidney problem, but does not have the classical malar rash. So, and there may be one patient who just comes with sudden fall in platelet count and what we call the autoimmune thrombocytopenia. And that is why these patients may not be diagnosed in time. In clinical practice, we see anywhere between 6 months to 12 months is the average delay in diagnosis before these patients are really diagnosed. Now, there are several criteria in clinical practice that we use to diagnose these patients. There is something called the SLE classification criteria for this is the SLIC criteria, the Systemic Lupus International Collaborating Clinics criteria. Now, these criteria help a clinician to diagnose these patients. However, for an expert who is routinely involved in care, all these criteria need not be satisfied. Now, once I see a patient with suspected lupus in my clinical practice, I would like to do some specific tests. Apart from doing the routine blood tests that we do in all the patients, like we would like to look at their hemoglobin, platelet counts, their kidney functions, liver functions, there are some specific tests that we do to diagnose lupus. And one of them is the anti nuclear antibody test. Now, this anti nuclear antibody test, which we also call the ANA test, is a screening test for the diagnosis of lupus. We call it the screening test because more than 99% of our patients will be positive for this test. However, one must remember that 5% of healthy people can also be positive for an anti-nuclear antibody. So what does this tell us? That just having a ANA positive test does not mean you have SLE. ANA is one test that can be positive in several conditions. It can be positive in infections, it can be positive sometimes in cancers, it can be positive in other autoimmune diseases. So whenever you are asked for an ANA, it does not mean you are getting the final diagnosis. However, if you have a very strong suspicion of SLE and we get an ANA test, and if it comes positive, then we do some confirmatory tests like a detailed ANA profile and then a long list of tests that help us confirm the diagnosis of SLE. And once we confirm the diagnosis of SLE, we always make a point to understand how severely is the patient affected. Because, as I mentioned, no two patients have the same disease. And that is why we always make a point to see whether kidneys are affected, whether any internal organs are affected before we start the treatment. And once the diagnosis is established, we then go ahead with counseling the patient and treating the patient. Now, before I start talking on treatment, let me briefly touch upon what really causes the disease. I'm sure the viewers must be wondering what caused this disease called SLE. Now, let me tell you, as per medical literature, the cause is not known. We do not know why some people develop autoimmune diseases. However, there are theories that say both genetic factors and environmental factors can be taken into consideration, and some people who have genetic predisposition and particular environmental exposures may end up developing SLE. But what is well known is that when children develop SLE, especially before the age of 5, we should always look at the genetics because there can be single gene defects like monogenic diseases that can present with SLE in very young children. Now, coming to the topic of pediatric SLE or childhood lupus, because I'm particularly dealing with children. So the first question I would like to answer is lupus in children different from adults? Well, the most common manifestations, the classical presentation, the testing strategy essentially remains the same. However, SLE in children is very severe or typically more severe when compared to adults. For example, the risk of development of a kidney involvement, severe nephritis, is much higher in children compared to adults. And as I mentioned before, if I see a very young child with SLE, I would like to do a genetic test. One of the common conditions amongst these genetic forms of lupus is the complement C1q deficiency, which we have diagnosed a few patients in our practice. When you see an adult physician treating a patient with SLE, they will never do a genetic test. But as pediatricians in young patients, we do genetic testing. Now, once we diagnose SLE, we sit with the family, the child, and the parents and give them a detailed counseling because this disease needs a long treatment. And sometimes, even if the disease is completely under control, they need a long term follow up, essentially, follow up for life. Now, since this is an autoimmune disease where our immune system is attacking our own body, the baseline treatment is focused on corticosteroids. Yes, we need to give steroids to our patients. I'm sure some of our viewers will be wondering how can we give steroids to young children? Let me tell you, if steroids are given in the right dose, for the right condition, for the right duration, we can reduce the side effects. The whole problem is when steroids are used by quacks unnecessarily, they cause havoc. Yes, most of our patients are given steroids, but then we give it typically for 6 months to 12 months, slowly reduce the dose and stop them, and steroids help us control the disease. The other medication that we use in all patients with lupus is the hydroxychloroquine. Now, this is something that we use in every patient because this particular medicine called HCQS, I'm sure some of us must have heard of this medicine during our COVID days, where HCQS was initially thought to be effective for COVID. Eventually, it wasn't. But this is one medicine, yes, we use in all patients with lupus, and it definitely helps reduce the future episodes of flares. We also use steroid sparing medications, something like azathioprine, mycophenolate, cyclophosphamide. The list is long, and as the name suggests, these medicines help us take off steroids. And these medicines are immunomodulators. They modulate the immune system in such a way that the disease can be controlled. And we occasionally get some very severe forms of lupus, especially lupus nephritis, where we use biologic agents or newer medications called rituximab. Now, naturally, these medications are given anywhere between 2 to 5 years. Now, the duration of therapy depends on the amount of disease that a particular patient has. For milder disease, a couple of years of treatment is enough. But if there is a severe disease with organ involvement like kidneys, the therapy goes on for 5 years. Now, depending on the organ involvement, the treatment might change. For example, the way I treat a patient with SLE who has kidney problem is very different if he does not have a kidney problem. So the medications may alter there. Now, the bone marrow transplant again is not the standard of care. It is only for that small subset of SLE which presents in a very young age and the genetic test is positive, we can think. But that is a situation for less than 1% patients. A very important question that almost every patient asks us is that is there a cure? Is there a cure? So my answer here would be like treating lupus is like treating hypertension or diabetes in an adult patient. Now, if you get diabetes, your sugars are high. We give medications, sugars can be controlled, and you can go off medications. But can your sugars again go high in future? Yes, you may be put back on medications. The same thing applies for lupus. In patients with lupus, our target at the moment is to control the disease and make them healthy. And once they are completely controlled, we kind of stop almost all the medicines. However, there is always a risk that this disease can come back, and that is why I said we need a lifelong follow up. At this moment, I would say there is nothing called cure, but if a disease is well controlled, they can lead a healthy, near normal life. But then there is one particular thing I would like to highlight here. I repeatedly spoke about the genetic forms of lupus that come in very young children. So when a young child before the age of 5 comes to me with SLE, we do a genetic test. And if the genetic test comes positive, say for a complement deficiency, this is one form of lupus where we can give complete cure. Yes, we can give a complete cure by doing a bone marrow transplant. However, this therapy does not apply to a majority of lupus. Only for a subset of lupus, which is genetic in origin, we can offer a curative therapy called bone marrow transplant. Well, the final bit of my My word on this particular disease would be as to what precautions should all patients take, because once a patient is diagnosed with this disease, many a times it comes as a serious shock to the parents. So we typically sit with them, counsel them, and tell them that these children will grow out to become healthy adults. No, there are no particular dietary restrictions, but because these children are put on steroids, they start gaining weight. So we ask them to take low salt, high protein diet. We ask them to take a healthy diet, avoid junk food, but no specific dietary restrictions. They can give a healthy, balanced diet that is cooked at home. They must avoid people who carry infections. For example, if there are people who are having viral infections, it is better you avoid coming in contact with these people, because these patients are on immunosuppression. And then we always recommend them giving specific vaccines, especially pneumococcal vaccines and other vaccinations, so that the risk of infection comes down. Pediatric lupus is more severe compared to adults, but when they are treated properly, most of them have a near normal life, and on medications, they tend to grow, go to school, and have regular schooling. However, if not treated sometimes appropriately, or if there is a delay in seeking medical care, it could be fatal. Now, let me tell you, pediatric lupus sometimes carries a fatality or mortality of 5 to 10%, and that's a significant number. And sometimes it is infections or a severe renal disease that can be the cause of mortality in these patients. That means this is not a simple disease. If neglected, it can lead to mortality. Now, any child or any adult who's got prolonged fevers, fevers that are going for weeks together, along with a lot of constitutional symptoms like weight loss, loss of appetite, hair fall, oral ulcers, joint pains with morning stiffness, if you have these symptoms may point towards lupus. But let me tell you, these symptoms can be seen in many other diseases. And that is where the clinician must think of this disease and investigate appropriately. Most often, in the investigations, we see very, very high ESRs. The erythrocyte sedimentation rate, ESR, is elevated. And then when we do appropriate testing in the form of the anti-nuclear antibody test, the complement levels, we can make a timely diagnosis. And once diagnosed, these patients can be treated. And once treated appropriately, they grow out to become healthy adults. So there are, I would say, two forms of lupus, one which starts in adults and one which starts in children. In childhood lupus, especially that starts before the age of 5, we give a lot of importance to genetic testing, because when an adult comes with lupus, there is no specific reason why they have developed lupus. That's what we say. The reason is not known, but we can diagnose by doing testing. But when a young child, say 3-year-old child, comes with lupus, which is a very uncommon scenario, it's not a common scenario, we will do something called a genetic test. And that can tell us that this is a particular gene defect that caused lupus in this young child, because typically autoimmune diseases don't start at such a young age. Now, let me tell you, lupus most often is not a genetic disease. So, if one child has got lupus, then it is very unlikely that the second child will also have lupus. Okay, so there are no specific precautions that the parents need to take in the next pregnancy. However, if your first child has a lupus which is genetic in nature, that means the genetic test has come positive, then you can test the fetus in the second pregnancy. But this is the rare situation. So the message I would like to give is, majority of the situation, lupus does not recur in family members. But in the same line, I would also like to tell, if there is a pregnant lady who is got SLE, those antibodies which are there in her body can be transferred to the fetus. And if they get transferred to the fetus, some of these neonates can develop neonatal lupus. And typically they have heart block, because those antibodies attack the heart, and their heart rates will be very low, and there can be other problems. And that is why pregnant females, like during pregnancy, if they have SLE, then they need close monitoring. Their lupus needs to be well controlled, and the fetus needs to be closely monitored.